Whilst we are waiting for the slides to go forward, whilst I was preparing this talk, I thought, well, the most or the best example of hybrid is actually a woman, because they say it's somebody that can do a place where many things can be combined and done in a good way to be different things being done by in the same setting. So I think being female, that's a good definition for being hybrid. But again, the word hybrid is a slippery word because by one definition, as I said, it's anything of mixed origin or composition. And we have hybrid roses, we have hybrid languages, we have hybrid cars. But a more narrow definition has hybrids as single functioning units that juxtapose different technologies. And when we consider the innovative energy use systems being applied in heavy equipment and trucks, perhaps hybrid definitions need a second look. And the most precise definition I encountered is that from Caterpillar. They say a hybrid is a machine equipped with a device to collect, store, and release energy during operation. And again, that is a very female description. So if... I couldn't resist saying that. So if we look at the definition of hybrid in the setting of a hybrid lab, I think the question we should answer is, will this be a cath lab where they will also do surgery, or will it be an OR, an operating theatre, where they have fixed imaging? And actually it's both. It's an integrated procedural suite combining the tools and equipment of a cath lab with anesthesia, obviously, with your surgical facilities and most importantly, the sterility of an operating room. If we specifically look at the definition of a hybrid operating theatre, it's a little bit different. It is defined as a surgical theatre equipped with advanced medical imaging devices such as fixed C-arms, CT scanners, and MRI scanners. And you might say, well, what's new? Imaging has been a standard part of the OR for a long time in the form of mobile C-arms and ultrasound and endoscopy. But the difference is if you specifically look at endovascular and also in adult cardiology, minimally invasive procedures, they require imaging techniques that can visualize smaller body parts, such as really thin vessels of the heart and the muscle, and can be facilitated intraoperatively through 3D imaging. Whether that is what we need in congenital cardiology needs to be discussed. So again, being a bit philosophical, we can say that the definition of a hybrid lab is a new workplace, and it's not making the cath lab into an OR or making the OR into a cath lab, but it must meet all the standard features of an OR and a cath lab without being a pure combination of the forward. Okay, that's fine, thank you. So where should the hybrid cath lab or the hybrid lab be? In the operating theatre or in the cath lab? And I think if we are honest, it's probably better served by having your hybrid suite located in the operating theatre complex, because it's easier to bring your operating theatre into the range for imaging that can then convert your cath lab into an operating theatre. Because your operating theatre needs positive ventilation, access to a scrub room, sterilization equipment, and specific surgical equipment and supplies. And all of these are already located in the surgical department. Obviously, one can convert a cath lab into a hybrid lab, but probably the cost to bring these rooms up to surgical standards would be higher, and also the size of a cath lab often is a problem. So it's often less expensive to share existing OR resources than to duplicate your scrub rooms, supplies, and equipment in another area of the hospital. Next slide, please. So what are the challenges in designing in a hybrid cath lab? I'm going to focus on three aspects. One, the staff and culture. 2, planning, and 3, design. So there are many different specialists, interventional specialists, who are seeking for hybrid facilities. On the one hand, the interventional adult cardiologists and obviously the congenital cardiologists, but also cardiac, vascular, and neurosurgeons and the electrophysiologists are looking for hybrid facilities. So we have to think of all these needs of all these different specialities, and the two most important functions of a hybrid lab is that it has to be able to diagnose, you have to use it as diagnostic facility, and interventional, combined transcatheter and surgical if necessary. So we need a team approach for successful implementation, and especially the hospital administration and the planners and the architects must understand the respective roles of each team. Otherwise, it will be difficult for them to design and help design the right facilities. we have to keep in mind which staffing which teams are going to work in these hybrid rooms, and they include your cardiology, your pediatric cardiology, electrophysiology, surgery, anesthesiology, perfusion, imaging, and all of these people have to be thought of when designing your cath lab or your hybrid lab. It's also important to remember, because of all of these specific different specialities, various layout scenarios are required, and not only for each team, but also during a particular procedure. Your room has to be adjusted to the specific procedure or speciality that is using your hybrid room. And the other thing is to convince your administration, hospital administration, that there is probably a benefit of a hybrid lab, because you can serve your patients in an innovative way. There's an ability to diagnose cardiac conditions and quickly intervene with catheterization, surgical or combined. But I'll get back to that, because I think you can do it also in a good way without necessarily having a superior hybrid lab. One of the most important things to keep in mind is the costs, and I think that is the main factor that will influence what you will get or design, and not only the costs of the design, but also reimbursement factors. If you do a hybrid procedure, what is going to be reimbursed surgically and interventionally and from the anesthesiologists. The second thing we want to discuss is what do you think of when you are planning your hybrid lab? There are some issues that will impact the design. 4 important things: equipment location, obviously we'll come back to that, your anesthesia material, the tables, the monitors. Important to keep in mind is the influence of vibration, your coagulation systems, and of course radiation exposure. Next slide. So often there's a different set necessary for each clinical discipline, and there could be potential conflicts over space placement. So again, communication is quite important, and teamwork is important. Specifically about the vibration sources, it's important to keep in mind that especially the biplane systems are extremely sensitive for vibration, and vibration testing is mandatory, and mitigation is necessary or must be done if necessary. And the most important vibration sources are normally generated from within the hospital, for example, your fan units in proximity to the lab. And these sources should ideally be eliminated at the source, or otherwise other isolation techniques should be used. Concerning radiation protection, in your hybrid lab, obviously everybody has to wear lead aprons, and not all the staff are used to wearing lead aprons. One should involve a radiation safety physicist to define which walls needs to be shielded. And what is important in this sense is to have good temperature control, because often if your walls are shielded, you will have higher temperature in your units, and your cooling systems often have to be adapted. One, for the comfort of the personnel, because it's often long procedures and the surgeons usually aren't used to working under those conditions. And secondly, for the patient, because surgeons also prefer lower temperatures for the metabolism of the patient during cardiac surgery. The next thing that is important in the design is obviously the size of the room, and the thing is that biplane units have a rigid vertical space requirements, and the ceiling height is quite important. If you look at the C-arm or the table movement, it is important to have enough space in relationship with anesthesia location. Obviously, care should be taken with the cabling, wiring, and hose to be kept off the floor. There should be a separate control room with wide windows, as we have in the cath lab. You have to have your monitor booms and floor conduits and computer drops. It's quite obvious, but it has to be thought of. In connection to the imaging systems, they should be compact and easy to move out of the way. That's probably the best for hybrid use. And in this sense, if you think about either monoplane or biplane, I think the benefit of a monoplane system is that it takes up less space. The ceiling-mounted gantry systems are easier to move out of the way, especially if your hybrid room is maybe used other days for ordinary surgery. So I think that's an important factor. It should not impede the floor space. And one should also give consideration to the size and the position of your digital X-ray flat panel. It should be on both sides for the surgeons as well as the interventionalists. The system should probably include digital subtraction software, analysis package for hemodynamic measurements, and picture archiving and communication systems compatibility, as in your ordinary cath lab. Again, concerning the size of the room, there are going to be more people in your room, your perfusionist, your anesthesiologist with their equipment, so you need a larger open space around your table to maneuver stretchers and equipment, and obviously to load your patients on the table. And also your imaging table differs from your normal imaging table in the sense that it should also serve the needs of the surgeons. The surgeons are used to tables that can be manually monitored, whilst in cath lab usually it isn't that way, or manipulated. And it must also be compatible with the production of high quality imaging. So again, serving both specialities. And last but not least, your surgical lighting should be free from overhead obstruction. Obviously, infection control risk should be thought of during construction. You should have a clean core, semi-restricted corridor for scrubs, hats and masks, scrubbing areas, and important is your air turnover and positive ventilation. Again, that is a factor why it's probably better to change your existing operating room into a hybrid room. Next slide. So which procedures are suitable for a hybrid lab? Well, I think, again, it depends on the definition, depends on who will be using those labs, but theoretically, those that require surgical access, for example, in congenital patients, when the size of the patient is a reason for access difficulty, for example, a premature infant where you want to do stenting of a pulmonary artery or an outflow tract, and you need right ventricle access, apical access for difficult procedures, for example, paravalvular leak closure, placing stents in peripheral pulmonary arteries where it's difficult to reach those lesions and also to fix the stents. In adult cardiology, it's often used in your percutaneous valve placements, obviously for thoracic and abdominal grafts, and also for large bore percutaneous assist devices. The second thing is if you anticipate that conversion to open surgery might be required. For example, again, during certain procedures, specifically in older patients, percutaneous valve implantation, where sometimes bailout or apical approach is necessary. Obviously, as I said, closing paravalvular leaks, and sometimes in specific cases of percutaneous VSD closure. And then there's the true hybrid procedures, for example, as done in hypoplastic left heart syndrome, whilst you have the possibility also to do it in two separate procedures. So it's not necessary have to be done in a hybrid room. It can also be done in a cath lab and in your operating room in 2 sessions. So this is an example of a transapical procedure in a small patient where the access was gained by a small stenotomy by the surgeon. The intervention was done, and it was done in the hybrid lab. Next slide. This is just the same example a little bit nearer. Next slide. This is an example of a transapical closure leak patch, closure of a patch leak with transapical access. Next slide. This is a picture of our hybrid lab. We have, again, our hybrid lab is in our existing operating room. It is not only used for hybrid procedures. When it's not used for hybrid procedures, it's used as an ordinary operating theatre. We've got a mobile C-arm. Next slide. You can also, if you can go one back, please, you can see your wide window area, your monitor room, which is necessary. Next slide. And again, your portable C-arm, enough space around your table, and a specific table compatible for surgeons. Next slide. So in conclusion, we can say that we are trying to bring together the best of both surgical and interventional technologies, and it's basically a paradigm shift that should be made. It's teamwork, and I think money plays an important role, and I think one should in your specific center decide firstly what your volume load of patients would be, Secondly, how much money you can spend. And thirdly, whether it will be used by other specialities. And I think that will influence the choice of design and the choice of equipment. Thank you very much.